Right, hello everybody, and welcome to our webinar to mark the launch of our Levelling Up Men's Health Case for Men's Health Strategy paper, and we're holding it just a couple of days before International Men's Day because it felt a particularly appropriate time to be highlighting the issues that men face and that International Men's Day seeks to address. As you can see from the logos, hopefully you can see the logos at the bottom of the page. This has been a joint effort, a team effort to get the case together and to work on the campaign with the Men and Boys Coalition, the Mankind Initiative, Engage, and Global Action on Men's Health, and of course Alan White, who has been an active participant in pulling everything together as well, which is greatly appreciated. We're running this as a webinar. Ideally, please use the Q&A functionality if you have any questions that you want to ask, and we'll answer them after the presentations, or if it feels appropriate during the course of the presentation. If you're using social media, the Men's Health Forum Twitter account is @Men's Health Forum, keeping it simple, and the suggested hashtag for today's meeting is #LevelUpMen'sHealth. So let's start with where we stand with men's health today. So about a month ago, the new life expectancy figures were published for 2018 to 20. And what they showed was that for the first time since the 1980s, there had been a decline in male life expectancy. Women's life expectancy declined a tiny amount, but men's life expectancy declined quite dramatically. And that was partly because of COVID. But if you look at the trends in men's life expectancy, you can see that it's been flat or stable for quite some time. And that's all in the context of men's health really not being at a level that we would want to see. So the normal definition for premature mortality is deaths under the age of 75. And if you look at that, what you can see is, for the most recent figures, is that about 40% of male deaths are under 75, 2 in 5. And for women, it's about a quarter. I mean, both of those figures that urgently and dramatically need to be improved. But the figure that we often look at the Men's Health Forum is the figure for people who die under the age of 65, the traditional age of retirement. People in working age, people in notionally the productive part of their life, in terms of, at least in terms of their work life. And what you can see is that 1 man in 5 dies under the age of 65 in the UK today, just under 19.1%, a truly shocking figure. And if you, next time you're in a group of 5 men, you know, think about that, and in terms of its impact. And that's something that, if you look, and this chart shows the number of deaths by age, comparing men and women, what you can see is from the age of 5 to 80, men are dying in larger numbers than women. Over the age of 80, at that point, we're going to run out of men. And so the figures go back the other way. But what you can see is there is this, men are dying more than women are throughout most of the life course. And the shocking figure that comes out of that is there are 676,000 working years of life lost in the working age male population. So if you look at deaths between 16 and 64, the number of years lost through people dying prematurely before the age of 65 is 676,000, really shocking figure. And that comes across all kinds of areas. So if you take cancer as a whole, what you can see is that Of that 676,000 years of working age life lost, 101,000 are lost to cancer. And these are all the cancers here listed that both men and women can get, except for breast cancer. And what you can see is that in all of them, men are much more likely to be dying from those cancers. Breast cancer, obviously, women are more likely to die. But in most other kinds of cancers that most men and women can get, men are more likely to die. A figure that is well known and is the second largest number of premature of lives, years of working age life lost, is suicide, where 76,000 years are lost. And you can see there that men are 3 out of every 4 suicides, with the peak age between 45 and 49. But it's also the biggest cause of male death under the age of 50. And we've seen it also in COVID. And here are the figures from the first half of this year. And what you can see is that, again, particularly in working age, men are much more likely to be dying from COVID than women are. And indeed, it was very striking at the beginning of the pandemic, even though men are 50% of GPs, of doctors, at one stage, 95% of deaths from COVID were men, and were mostly men from minority ethnic communities. But there's an important point about men's health, which we keep coming back to, which is that men's health is very unequal. So if we look at areas of deprivation, what we can see is that firstly, there's a very big age gap or life expectancy gap. There's a 9.4-year gap between men in the highest areas of deprivation and the lowest areas of deprivation. And what you can also see is that it's a bigger gap than there is between women in the equivalent areas. And there's a strong case when it comes to health that men are more unequal than women are. It's rightly pointed out very often that most billionaires are men. But it's also the case that some of the most vulnerable people in our society, such as homeless people and reported victims of modern slavery, are also overwhelmingly men. And there was an important piece of work also done on suicide inequalities. I mean, you see a very similar picture if you look at areas of deprivation. But this is a piece of work that was done by Public Health England, showing suicides by occupational group. And if you look at the bottom, or if you look at the top, you see unskilled occupations, which have the highest rate of suicide. And if you look at the bottom, you see managers, directors, and senior officials, which have still a high rate of suicide, but the lowest rate of suicide. And we often talk about the fact, and just earlier I referred to the fact that men are 3 times more likely to die from suicide as women, but somebody in an unskilled occupation, a man working on a building site, is 3 times more likely to die than somebody like me, who's a manager, a director, or a senior official. Not that I'm a senior official, but I'm a manager. And one area where the inequalities become even more dramatic is if you start looking at healthy life expectancy. So I talked earlier about a 9.4-year gap in life expectancy. But when you look at healthy life expectancy, it's an 18.4-year gap in healthy life expectancy, a truly shocking figure. Now, the classic thing that we normally hear at that point is, well, it's because men decide not to go to the doctor. So is it because men don't go to the doctor? And here's a cartoon that has been used in the world of men's health around the world for at least a decade and possibly longer. And the truth is that men are less likely to go to the doctor. And this is a study that was done published in about 2013, showing consultation rate by age and gender in the UK in 2010. They did some corrections to take out the extra visits related to fertility, but you still see a gap. The orange, well, this line here, the middle line, is women consultations, excluding reproductive events, as they call it, and the bottom line is men going to the doctor. But a lot of it seems to be to do with men's usage of health services in working age, because as soon as men retire, they go to the doctor exactly the same amount as women do. So there's nothing inherently male about not going to the doctor, because retired men go to the doctor just as much as retired women. It's much more to do between the relationship between men and health and their work that leads to different behaviors, and the health system and men's work that leads to these different health behaviors. Now, I touched earlier on cardiovascular disease. Men are 76% of CVD deaths under 65. It's about the same proportion for men under 75 as well. But they are less likely to be reached and engaged with the NHS health check program. And we've seen these differences in behavior and failure to effectively engage very recently in the COVID vaccination program. So the UK HSA publishes figures showing what proportion of the population has been vaccinated by gender on a weekly basis for those into such things. And the NHS also publishes them. They do it in a slightly different way. But what comes across, and this next chart is a calculation we've done where we just subtract the two figures. And so we subtract the percentage of men in a particular age group. We subtract the percentage of women in a particular age group from the percentage of men in a particular age group. And what you consistently see, however you look at the numbers, and these are English figures, but it's broadly true for Wales and Scotland as well, is that particularly under 50 or so, men are not getting vaccinated. Now, interestingly, when all the work has been done on attitudinal factors and skepticism about vaccination, the traditional, oh, I'm frightened of it, isn't that strong amongst men. And so there was an expectation based on the original figures that there might not be a problem, although we were warning early on that there probably would be based on previous flu vaccination experience. What's really interesting is that the kind of arguments that are made by the men who are not getting vaccinated versus the women who are not getting vaccinated appear to be quite different. And that ties into our next point, which is gender-informed interventions are needed in many areas of health, and they work. And Alan will be talking about this in detail later on, but we've published a couple of guides that those of you who are practitioners may know or have found useful: how to make mental health services work for men, how to make weight loss services work for men, both areas where a gendered approach is needed. But the example, and I unapologetically have taken an example that's highlighted in the recently announced Women's Health Strategy consultation. So they rightly say in the area of heart disease that women in the UK have more than double the rate of death in the 30 days following a heart attack than men. And again, they absolutely rightly say, and therefore we need improved heart attack care for women in secondary care, and we need further research into the root causes and necessary treatment. But if you look at other figures that relate to heart disease, so a good example would be untreated high blood pressure, which is one of the biggest risk factors for premature death. Public Health England produced figures showing that 15% of men have untreated high blood pressure versus 10% of women. And so what you see there is that for case finding and early detection, there's a problem with men. And so there needs to be more work with Know Your Numbers campaigns, improved primary care and outreach, male-targeted NHS health checks and blood pressure checks. But the key point it shows here is that if you take a gender-blind approach to heart disease, you will fail men and you will fail women. And a gender-informed approach is better for men and better for women. And a lot of other countries are now putting in place normally men's and women's health strategies sitting alongside each other to tackle these issues. And here are three that I think will be of particular interest. So we've got the first one is Australia, and they're now on their second national men's health strategy. The second one is Ireland, and they're also on their second national men's health strategy as a special sort of focus area for the Healthy Ireland overall public health strategy. And then the third one I've got listed here is the World Health Organization for Europe men's health strategy, which is one that actually the UK was one of the countries in Europe that endorsed it when it was introduced. And this might be a bit of a stretch, but the Irish introduced their men's health strategy in 2008. And if you find two comparable years to look at in terms of life expectancy, in 2005 to 7, they had lower life expectancy than the UK. And by the time you get to 2015 to 17, they have higher life expectancy than the UK. So it's probably a bit of a stretch to say that the strategy on its own did that, but it is quite striking. It's also striking that when the Women and Equalities Committee did an inquiry into the mental health of men and boys, the conclusion from Maria Miller, who is the MP who was the chair of it, unfortunately there wasn't ever a final formal report, but she wrote a letter to the minister in October 2019, just before the general election, saying the Department of Health and Social Care should give serious consideration to creating and implementing a national men's health strategy like those launched in Ireland or Australia. 18 months later, Lord Hunt asked a question in Parliament to say, have they assessed the merits of developing a men's health strategy following the launch of a women's health strategy? And the answer was, we have made no such assessment. So there's clearly a need that, this shows that just on equity, but also to get the results that are needed to get the improvement in men's health needed, there is a need for a men's health strategy. But Alan is now going to take us through those arguments in more detail. Alan has a tremendous record in the world of men's health. He was the world's first professor of men's health at Leeds University. He's a founder and patron of the Men's Health Forum. And even as we, well, not as we speak, but certainly at the moment, he is recognized by the World Health Organization and working with them in the Western Pacific area to develop their men's health strategy and priorities. So, Alan, over to you.
Thank you very much, Martin, and for that introduction, also for the excellent overview that you've just given. This is such an important point in the world of men's health. We've looked at this such a long time. In '92, when Kenneth Kalman, in his State of the Public Health, had a chapter on men's health, that was seen as revolutionary. We've never had anything that's appropriate, came close to giving an overview of men's health before in any kind of government documents. And so when in '92 he said that this was an important issue and that we could really be doing something about it and we can improve the health of men, that was an exciting point. 2001, I was fortunate enough to have the opportunity of working with Yvette Cooper and the team at the Department of Health to pull together a scoping study on men's health. And I think, again, this was the first time we'd ever sort of looked overall at men's health and what should be happening. And it was disappointing that my report came out just before the election and everything changed and it never went anywhere. And also disappointing to think that since '92, we've never had any kind of government statement on men's health. And now we're having a women's health strategy. It seems like we are perhaps at a point where the government should accept the fact that there are issues around men's health and a coordinated approach should be looked at. During the time after those reports came out and at the Men's Health Forum, we saw that Australia was bringing out their men's health policy. Ireland were doing theirs, and we were wondering, well, should we be doing the same? Should we be pushing it at that time for a strategy? But we were fortunate. We thought, right, we've got the Equality Act, the 2010 Equality Act. This is a great move on from the Sex Discrimination Act, where you had to be reactive to events. This was proactive. And we thought that this would now change the way all services were looking at gender. Men were a protected characteristic, were women, and that we would be seeing that all the services would start to focus in and say, well, all right, so what are we doing about men? It wasn't as if there wasn't the information. We had the Cancer Research UK was recognising there was an excess cancer burden. Significant organisations like Samaritans, Mind were all also recognising that there were issues. And so we assumed there would be a natural move towards all services starting to see the need and to move forward. It didn't happen. And when I was fortunate enough to work alongside the World Health Organization, pulling together their report and their strategy, it was a tremendous reinvigoration of the debate. The need was very visible, and ironically, there was a women's health report done by Europe, and the men's health one followed. So I'm assuming that in exactly the same way as with the World Health Organization, we had a women's health report, and one of the outcomes from that would be that there will be a men's health one. And when I did, when we looked at this report, one of the things that drove it was exactly what Martin has just been saying. The missing men was a label used within the World Health Organization towards Europe free of avoidable non-communicable diseases. And they noted that the adverse mortality among working age men has a profound demographic, economic and political impact on the region. The burden of premature mortality is so great, observed for so long, that it's just seen as normal. And you get the fear that actually it's just seen as normal within the UK as well. Whereas they're looking at it between countries, where we should be looking at it between deprived and non-deprived areas. I was very fortunate to lead two big reports in Leeds. One was the state of men's health, and one was the state of women's health. The state of men's health came out in 2016, and ironically, that was the other way around, because one of the recommendations that emerged from that was that we should have a women's health report. And having that detailed view of what was going on within this huge city has transformed the way that they are now looking at the way services are provided. And I think that we as a country need to have that same kind of renewing of our view of the population. We should be looking to see what are the issues facing men, what are the issues facing women. Because what you find is there's lots of similarities, but there is a huge amount of differences. The biology, the social cultural socialization of men and women, the lives that men and women leave so many of the diseases that we are at the moment just grouping all in together with one approach actually may not suit either men nor women well. And one of the things that came out from the report, across nearly all causes of death, men in Leeds are more likely to die than women to die at a younger age. And they are nearly all preventable and are related to lifestyle or social conditions. And we stated quite clearly that men's health matters and men's health can be better. One of the main messages, however, was that we have to have a concerted effort. We can't just stand back and let all this happen by chance. We have to be getting in there and making changes to address the challenges that men are facing, the physical and emotional challenges that they're suffering from at the moment. We have to reach out and target them more effectively. And we also be having a look at the broader issues, the social determinants which are leading them to have problems in the first place. And this has had effect. I mean, Ian Cameron, the Director of Public Health in 2018, his whole report was focused around men and women's health, men's health chapters, women's health chapters. Wouldn't it be nice if our Chief Medical Officer just mentioned men's health? My report highlights a number of public health issues that are causing the men and women to get worse. Reversing these worrying trends needs to be a priority. Our actions must be based on a greater understanding of underlying gender issues than we have in the past. So what's our case? We have to level up. We are still losing too many men to premature death and ill health. Martin raised the issue of 676,000 years of life lost. If you look across the lifespan, it's 3 million years of life lost because of men's premature death. Large disparities based on where you live. We have now got to have the time for action. We have a men's health strategy for Europe, which Europe signed up for. Other countries have strategies. We're now getting a women's health strategy. Where's the men's? And we have gender equality legislation, which says that we should be looking at the genders equally. And this isn't happening in a stable world. Everything is changing, and we have to be on top of it. And I don't think we are. We've got changing position of men's place within an aging society. I'm going to look at that in a second. We've got to be looking at what's happening with men. We've got to be thinking about what new lives men are leading. It's much more complex than it was before. We've got changing views on masculinity. Gender equality is so important. Gender roles, family models, fatherhood. We've got changing work patterns, vulnerability in the workplace. What are our children doing? How are boys coming out into this world nowadays? We've got a much greater recognition of diversity. It's not just men. We're going to come on to that in a second. A more health-aware male population. Men are just not sitting back. Every day now you're seeing more and more about men's recognition of the need for mental health services and other services. So it's not a passive group that are sitting in the background. This is an active group that will be asking for this and not understanding why we're not getting it. This is XY chromosome. A lot of people think that that little thing there, which is the Y chromosome, it causes all the problems, can also be part of the solution. We have to remember that have to be part of any kind of solution as we go forward to improve the health of men. But it's not just our biology. But our biology, people will argue most of the research is being done on men. And you are right. And there are huge biological differences. Our lung size is different. Women develop lung disease differently. Women develop colon cancer differently. Musculoskeletal problems differently. There's all sorts of reasons why our biology matters. But most of the research that was done on men was done on men's bodies. It wasn't done with men. I don't think we're very much further on in really understanding what drives men towards the health service, what are the impact of ill health on men, how do men see themselves, etc., etc. So we have still got a massive amount to do on understanding the issues. And it's not just men, as in men, we are a very diverse group. We are stereotyping men into a one sentence is not helpful. We have to look at our sexual gender minorities. We've got to look at our education attainment. We have to look at where men are living, their marital status and relationships. Huge number of men are living alone. We can't assume all men are part of relationships. Men as carers, now over the age of 75, there's more male carers than female carers. What services are available for them? We go on and on. It's not just ethnicity, it's ethnicity linked to sexual and gender minorities, to disability, to age. We are complex, and any complex problem can't have a simple solution. We have to have a strategy. We have to stand back. We have to look at it. We have to think about it. We have to be thinking as a government, so what are we doing? What are we doing and where are we going? And we have to think about this young man and where he's going to be in 20 years' time, and then in 60, 70, 80 years' time, because the world is changing. It's quite dramatic. When you look at the population projections, between 2018 and 2038, it's projected there will be 1.55 million more men over the age of 75. That's phenomenal. That means there'll be more men over the age of 75 than women are now. And that's only in 17 years from now. And it keeps going up. And that's a 66% increase of men, and it's a 51% increase for women. So men are actually growing. The fastest growing group in the population in the UK is older men. And we're also getting into older men. And not many services are catering for older men. All the services have been focused on older women because that's what we've had. So what are we doing for these older men? And how are we supporting them? If you actually look at this from a different perspective, it's even more worrying. At the moment, 59% of our male population is working age, 15 to 59. 22% are over the age of 60, 18.6% between the age of 0 and 14. By 2038, the older population has risen to 27.6%, and the working age population has dropped to 56.1 and to 54.6 by the time we get to 2048. Women, it's even more dramatic. By the time we get to 2048 for women, we are down to 51% of women, of working age population, and the rest are in the older population. We have got to keep this population, our working age, our young men going into their working age, and the working age men going into their older age, as fit and as well as possible, because otherwise we are going to be living a long time with chronic ill health. We have got to be thinking about how we maintain the health of our population so that we are able to manage it, because the cost of this is going to be phenomenal if we're not careful. If we look at the current frailty cohort within Leeds, this is the women on the frailty cohort. They have currently 150,000 women in Leeds with one or more long-term condition, and nearly 20,000 recognised as very frail. This is the men. Now you imagine what's going to happen as those numbers go up in both sides. Taking obesity as a sample about how to keep men healthy, 68% of adult men are overweight or obese. And this visceral fat, we put it on around our middle. And that gives us a higher risk of hypertension, hyperlipidemia, diabetes, the fat-related cancer, prostate cancer, bowel cancer, liver cancer, kidney, esophageal, pancreatic cancer, and erectile dysfunction. So we put our weight on in the worst possible area. We put it on quickly. Now look, between the age of 16 to 24 and 25 to 34, we dropped from 55% of the male population being normal weight to 39. And by the time we get to 45 to 54, we're down to a fifth of our male population as a normal weight. For women, it's much slower decline. By the time we get to 45, 54, we've still got a third of women are still of normal weight. We know that obesity for women is a nightmare, but for overweight, because of our visceral fat, it puts us increasingly. Who's looking at this? Who is focusing on getting weight loss management out to young men? We know it's not the health service, because 25%, when we looked in Leeds, 25% of men at this age hadn't even had their weight taken by their GP, compared to 8.7% of women. And it's sort of also reflected in the fact that when you look at weight management in Leeds, similar numbers of men and women overweight, but the majority of the people who are going for weight loss management are women. And it's mostly done because commissioning of services is done by people. And if you put a weight loss group on, the easy people to recruit to make up your commission numbers are women. But ironically, when men get to a weight loss group, they're more likely to lose weight. And we have to focus on getting men to the service. And the same for smoking. That more men smoke, but more women go to smoking cessation, but more men who get to smoking cessation are likely to stop. Suicide, Martin has already showed the numbers. When you look at the rates, that it's just a start. And actually the rates show how older men the numbers in the older population are quite horrific. But when we look at the audits, the excellent audits that are being done of suicide in Leeds, you see that it's not just men, and I think Martin alluded to this before, so we're perhaps repeating ourselves a bit, but they're mostly 40 to 65, mostly male, but they're living in deprived areas, they're living alone, they're living a single separated divorce, they're experiencing workinglessness, relationship problems. All of this is meshing together with the social determinants of health. And so we have to be better able at reaching into vulnerable groups. But it's not just something special. We think that part of the difficulty, it's a bit like weight. What the meaning of weight to a man is different from the meaning of weight to a woman. The social processes by which weight is a meaning to men and women is driven by all sorts of factors. And as with men's emotional reaction to difficulty, when you look at use different scales, you find that actually you can pick up as many men as women with depression. You have to look and see what are the issues, and how about anger management, how about substance abuse, how about alcohol levels, what are they doing to men's emotional and mental health, and are they being measured in terms of assessing risk? And then is that being fed into all the services? Rise High was an amazing initiative as a consequence of our report in Leeds. When we looked at social housing for men, we found that men are not seen as vulnerable, and therefore they were put into wherever there was housing. 85% of some of these flats had young male, single, low self-esteem, depressed, socially isolated men. Terrible position to be in. So we've had to put initiatives in to try and get to those men, because no one else was doing it. And the reason why no one else was doing it, because these men are mostly invisible unless they are a nuisance. They don't flag up on anyone's system. That was the commissioner that said that. And we've had a tremendous work being done in Leeds in the Men's Health Unlocked. And actually, ironically, at this very moment in time, the National Lottery are considering whether they're going to get an increase in their funding to keep them going. But they've been working in those flats. They've been going in and giving tablets to these isolated men so that they could keep in contact. And the Men's Health Unlocked quickly learned the key to our success was not just the quality of our activities. So it's not just about putting on good things, but it's about engaging the men, engaging those difficult to reach men. So we have to have a learning process, and that has to be driven. The Office for Health Improvement and Disparities see that we have to make a difference to the most deprived areas where they see 10 years difference. And they've noted men, this is good, but how are they going to do it? How are they going to do it? How are they going to prevent health conditions? When actually what you tend to find is there's no one coordinating this. There's no one saying how it should be done. Great examples of work with men. The Men's Shed, the Andy's Man Club, the Fit Fans Weight Loss Initiative, Men's Health. It's fantastic. It's driven by passion, by local commitment, but not by central policy. It's only happening by chance, not by design. There wasn't anything pushing forward to say we have to look at this area of men's lives because this is we recognize it nationally as being a significant issue. Men's initiatives do make a difference, but they need mainstreaming. It's got to be seen as everybody's business. Everyone who's running a weight loss group has to think, where are the men? Everyone running addiction, where are the men? Where are the men? How are we reaching out to the men? What do I need to learn to be able to do my job better so I can reach to these people that are, people say, are difficult to reach? In most cases, they're not difficult to reach. You're just not using the right approach. And we need people to recognize that they might be needing to do things differently. And what's our national position on men and cancer prevention? What's our position on men and weight loss, our men and health checks? Chlamydia screening. Chlamydia screening initially was set up just for women. Obviously men had nothing to do with it. And then we persuaded them that they had to include men in it. They changed it. And then they started to find men were being screened and men were coming forward. Surprise, surprise. Men do care. And now I see that they're thinking they've taken it out again. And you think, what's going on? So men are invisible in policy and strategy. Currently, very few policies make specific reference to what's happening to men. There's a lack of strategic direction for national and local planners of service. And unless someone is giving them a prod, most people take the easy route. And I go back to that quote, these men are mostly invisible unless they are a nuisance. It's a fragmented approach, focuses on individual parts, smoking cessation, weight loss. Who's looking at the clustering effects? Most men have a cluster of lifestyle issues, mental health and. There's no joining together of the lessons learned. Everyone has to start again. There's no proactive planning or reacting to emerging issues, as was seen by the COVID problem we had with men. Oh, look, we've got a problem. Yes, we knew that was going to happen. And why should we put all the responsibility on women's shoulders? Why only focus on women to find a solution? That just doesn't make sense, and it's not fair. And it's not fair on women, and it's also not fair on men. Men's role in sexual and reproductive rights, men's role in gender equality, men's caring responsibilities. We are here, and we should be doing this. And often it's a case of we just need to find someone who can give us direction. So we have to work in partnership. At Men's Health Forums, we've always ensured we've worked with women. It's just a part of our core. It's not a competition. It's not what we've seen in Leeds. The Men's Health Unlocked works closely with Women's Lives Leeds. We've been discussing intimate partner violence. We've been doing some fantastic work up there. We've got to be thinking about this as a gender relations issue. So why do we need a men's health strategy? We've got a lack of coordinated service provision. We are generally invisible. There is an ad hoc development of small-scale initiatives, and we can't afford not to. So what do we need to happen? We need a comprehensive men's health report, first off, that brings together all the key stakeholders, policymakers, statutory and voluntary sector, and men themselves. A national strategy that can act as a driver for local action to meet the differing needs of men across the UK, and leadership in each UK nation that helps coordinate action is acting in preparation for the challenges ahead. If we'd had someone in that position, COVID-19 might have been different. And a research agenda for men's health that is multidisciplinary. And I think we really seriously need a national centre for men's health. So I'm going to leave it there, Martin. So thank you very much, all.
I'll unmute. That was amazing, Alan. Thank you very much indeed. Right, we have about 16 minutes left before the end of the meeting. Do people have any questions or comments? We have a Q&A open, we have chat open. If you raise your hand on the system, I can bring you into the conversation. Does anybody have a question or a comment or want to say something, want to say a few words? I can't believe that we've answered every single question. Oh, right, we have a question. How do you feel we get this embedded in local authority planning and policy? It is a question from, it's abbreviating it on my screen. Hold on, it's a question from Sharon. Do you want to? I mean, you've done it, Alan. Do you want to?
Yeah. Well, what we did, which was quite remarkable, Leeds was spending 800 million pound on external services. So what we put into the market position statement, a simple statement to say, look, what you're producing has to take into consideration the gender of the person you're seeking. You've got to be thinking about how do you reach out. If you're putting on a weight management course, how many men are you going to pick up, and how are you going to recruit them? And putting targets around, not just persons. One of the things I said in the report was stop using the term people. They're men, they're women, they're trans. Stop using the word children. They're boys and girls. Stop using the word parents. Parents these are mothers and fathers. And as soon as you say mothers and fathers, you have to start thinking about, so what are the implications for fathers? What are the implications for boys when you're looking at initiatives around social education, etc.?
And if you're not directly in local government and you want to ask, I mean, you know, there are methods of getting involved. I know Hampshire did some work because I spoke to the cabinet member at the Hampshire County Council who's responsible for public health, and we started talking about the issues of men's health, and that made a real difference. We've produced a guide to scrutiny, so if any of you are in local government or councillors, we did a joint report with the Centre for Public Scrutiny, which is available for free download on our website. So coming back to Alan's point about a report, you know, one of the first things that's useful to do as a member of the public or as a councillor or in any other role is to just start asking questions, and maybe ask how they're doing on weight management services. Ask what is the difference in vaccination rate in the council area. You know, ask the Director of Public Health, what's the difference in vaccination rate on between men and women. Often just getting those conversations going can be a really powerful thing to do.
Do a report as well. Do the men's health report. Do the women's health report. Sorry, Pete. Sorry.
Yeah, absolutely. If you have the capacity and the capability to do that, that's brilliant. Any other questions or comments, or somebody wants to stick their hand up, or I don't know if Sharon wants to respond to that comment. Anyone else want to have a go? We have a question from Peter, which I'll come back to in a minute. Somebody want to ask a question? I can't believe we've answered everything.
Similar. Are you able to do similar?
Oh, right. No, here's a very good this. Are you able to do similar presentations to companies or groups? Interesting you say that, because I had actually just done a slide which was about to put up to say what people can do to help, which I can throw up on the screen. Let me see. There we go. That one. What can people do to help, and what else is going to happen next? So the first thing is, if you haven't, please do sign up to join our campaign. Help us build a strong coalition. And so absolutely, we will come and talk to organizations. We can't speak, through the Men's Health Forum, we're very happy to do talks on men's health in any organization. And we have training, and we have programs like our Men's Health Champion program, where we can help educate your organization in the issues of men's health and how to engage on men's health more effectively. For the purpose of this campaign, we are also, if you're an organization and you'd like to know a bit more and have a discussion, or you need an internal presentation in order to persuade that organization to sign up, we are very happy to do that. So we're happy to help in a range of ways. We're happy to come and present for free to decision makers or people involved in making a decision on the issue of signing up to back this campaign from Men's Health Strategy. And if you want men's health training for your staff or your organization, that's also something we can help with. And if we can't help, we are happy to signpost towards other brilliant organizations out there that can. Other things that people can do, you know, we are in the process of wanting to build a strong list of public supporters, both in quality and quantity. We want public supporting organizations, and if you are able to do that and to show that there is a broad base of support, because we want to, you know, as part of our wider program, which is to get government commitment starting in the UK Parliament probably, but we're also very interested in working with people who want to get a similar commitment in the Scottish Parliament and the Welsh Senate, or in Northern Ireland, to get commitment to a men's health policy. And if you have comments as to how we can make our case more persuasively, then that would be helpful too. And if you know, and if you feel that you're confident, and we will be issuing ideas and ways for people to get involved in this, but also contacting elected officials, because our judgment has been that we do need that political change to get a men's health strategy in place. We've historically done a lot of work with civil servants and people behind closed doors, and many of them understand the case, but to get the change we need, we are going to need political change at the top. I don't know if we have any more questions or comments, or somebody wanted to say things there. You should, I hope, be able to see the ability to put your hand up. There is also the ability to chat. I don't know if anybody has anything else. I'm happy to. Is it possible to get a copy of this presentation? Yes, absolutely. We will email a copy of this presentation to everybody who signed up to attend. In fact, we will email a link to the video of this presentation, as well as copies of the content of the presentation, of the two presentations, to everybody that expressed an interest in our men's health strategy, and we'll also post it on social media.
Peter's asked, what about APG?
What about the all-party parliamentary group? Yeah, so let's come back to what we're doing separately. So there is a new all-party parliamentary group on issues affecting men and boys. So they're not just looking at men's health; they're looking at all issues, and it's a great, you know, it's a great institution. It's off to a really strong start. doing impressive work. They are with parliamentarians at the moment doing a series of sort of listening sessions, learning sessions on APPG meetings, all party parliamentary group meetings, on the case for a men's health strategy. And so they've called in experts from other countries, from Ireland. They've called in people and are calling in people from a range of different condition groups. Obviously, the Men's Health Forum has been involved. Alan's been involved. Global Action on Men's Health with Peter Baker's been involved. So that's a very important part of what we'll be doing. In terms of other things that we're doing, obviously we are writing to the ministers and the civil servants to make them aware of our new case for a men's health strategy and asking for a response. There will be an International Men's Day debate in Parliament on November the 25th, and we will be sending out briefing materials before the end of this week to make sure that, or to ensure that parliamentarians have the kind of information they might need in order to make to talk about men's health issues in that debate. And alongside all of that, we are also trying to understand whether the government's approach to date has been consistent with its legal obligations under the Equality Act. But frankly, our primary approach is to win the argument for a men's health strategy rather than sort of people feeling that they're forced into it through legal action. We want there to be proper, genuine commitment from the centre in order to make a men's health strategy succeed and work. And coming back to a point Alan made, we're particularly keen to work with women's organisations. We strongly support the women's health strategy. We think it's a great thing that's been doing because, if nothing else, it proves the point that a gender-informed approach to health can make a real difference to health of people in Britain. And all we're saying is, and it's true for men as well. And we believe if we can get that commitment, it'll make a real difference. Do we have any other questions or comments? I'm just looking at the chat. Can I thank everybody, by the way? There's quite a few people who've been putting in some comments here to say that they support us. We're very keen to start adding names to our document to show the list of supporters, and certainly online to show our list of supporters. So thank you, Nav from Dads Unlimited. Thank you, Jerry from Cancer Focused Northern Ireland. And thank you, Yana from Man Behind the Smile. So really appreciate those messages of support. So are there any other questions or comments, or people who want to stick their hand up and say something? If not, we may even finish 3 or 4 minutes early. Alan, is there any last comment you would like to make?
No, he says, inevitably there is a lot we can say. We're on a road. We've been on a road for a long time. When we started working in men's health in the 90s, people stood back and stared at us and said, "What are you on about? What on earth are you doing?" And over the decades, what we've come to see is all that work we did in those early days is coming to fruition. It's been a slow burn. And actually at that time, if someone had said, "Here, we're going to set up a strategy for men's health," we would have probably been unable to give them a reasonable answer as to what actually we should do. But we have learned a phenomenal amount. We have been seeing initiatives and research, and we've seen countries across the globe looking at men's health. We're coming to this now with our eyes open. We have much clearer ideas of what needs to be done and how and why. The argumentation is solid, and we're more mature. We know what we're doing. So I think now it's an opportunity for the government to draw on that expertise. you look and see how many organisations are involved in this already, and we have. If they're open to a conversation, to sit down around a table and start to listen and to start to think about the possibilities that might exist if we take this forward, I think that they will be going for it. Fingers crossed.
I don't think we can finish on a better note than that. So thank you very much indeed, Alan, both for all the work you've done to get men's health on the agenda. Thank you to everybody who's come along and contributed and taken an interest. Your support is greatly appreciated. Yeah, we will be checking in with people as the campaign proceeds and giving people a chance to get involved. But we're very grateful to everybody who's attended. Thank you again to Alan, and thank you all for coming. We look forward to reporting back sooner rather than later, but certainly at some point, on the results of a successful campaign, and then the work will really start. Thank you.